Okay, hi guys, hi everyone. Welcome to today's Quesmed Study Hub collaboration on SBAs in Cushing's and Conn syndrome. We're joined by a personal favorite. I'm not biased here, but we're joined by Dr. Jamie, who's going to be taking us through this amazing SBA Cushing, SBAs in Cushing and Conn syndrome. And if you've been to any of his events before, I'm sure we're going to be amazed, and we're going to learn quite a lot in this session. But before we get started, I just wanted to say, if you're new to Study Hub, welcome to Study Hub. It's a great educational platform that goes to provide lectures pretty much every single day. So do make sure that you follow us on Instagram at Study Hub Med, and the same with Facebook, to keep knowledge on all these amazing events. Also, we have snappy SBAs and some great revision tips that you guys would really benefit from if you follow us there. A few housekeeping rules. This session will be recorded and will be available on the Study Hub website in around about 10 days, and will also feature on the Quesmed's YouTube channel in around about 7 days. The slides will not be available, but this recording will be. There will be polls throughout the session for you guys to get involved, so please make sure that you're answering the questions and using the polls. If you have any questions, please do make use of the Q&A feature, and Dr. Jamie will answer those questions at the end. And at the end of the session, please do, I'll send in a link for all those that are attending via the Zoom link. I'll send a link to the feedback form. If you just scroll down, it literally take you 2 minutes, and it's a great way for our educators to know what to do better next time. So without further ado and enough of my rambling, I'm going to pass it on to Dr. Jamie for this awesome SBA session.
Thanks a lot, Zanya. So as you said, I'm Jamie Arberry. I'm a doctor based in London, and today I'll be doing SBAs in Cushing syndrome and Conn syndrome, and focusing in on mainly how we investigate these, what the screening tests are, what the diagnostics are, what the causes are. We'll have 9 questions today, and after each one I'll go through why it's the right answer and a bit of an explanation. And as Zanya said, I'll answer all the questions at the end. So going straight into it, question number 1. A 34-year-old man presents to the GP with a 3-month history of weight gain and lethargy. He has a past medical history of Crohn's disease, which is adequately managed with budesonide 9 milligrams daily. On examination, you note abdominal obesity, bruising of the arms, purple abdominal striae, and reduced power in the proximal muscles of the arms and legs. Which of the following is the most likely explanation for this patient's physical findings?
"30 seconds left, guys."
Great, so I thought we'd kick off the show with a fairly straightforward one. So this is a typical presentation of Cushing's syndrome. All of these features, the abdominal obesity, bruising of the arms, the abdominal striae, and the proximal myopathy, they're all very typical of Cushing syndrome. In hypothyroidism, you can get some proximal myopathy, and you can, but you tend not to see the bruising of the arms and the abdominal striae. So Cushing's syndrome is basically the clinical manifestation of chronic glucocorticoid excess, and that can be exogenous or endogenous. So if we look at this picture here, the symptoms of Cushing syndrome, there are quite a lot of manifestations of Cushing syndrome, and quite a lot of systems in the body that can be affected. But I think all of us are kind of fairly aware of the main physical findings being the moon face, the buffalo hump, the abdominal obesity, this proximal myopathy. With the skin, you get thinning, bruising. You can get acne and excessive and hirsutism, which is excessive hairiness. Cushing syndrome can increase your risk of fractures. And in terms of reproductive health, it can result in irregular or absent menstrual periods. And it can also affect you psychologically, causing all sorts of different manifestations like depression, anxiety, irritability. And it can also affect your glucose tolerance, so you can become intolerant and diabetic with Cushing syndrome. You can become hypertensive with Cushing syndrome, and you have increased risk of infections with Cushing syndrome. So it's quite a really vast kind of vast effects on the body. And the causes can be categorized into, as I was saying before, exogenous or endogenous causes. So exogenous causes are by far the most common cause of Cushing syndrome. And that's just chronic steroid exposure from a clinician giving a patient steroids. So in the previous case, it was budesonide, which was being used to treat Crohn's disease. So often when we start steroids, we want to try and wean them off as soon as possible. And if a patient needs, and we'll try to use a steroid-sparing agent to try to wean off the steroid. Endogenous causes are much rarer, but they can also be categorized into different causes. So there's Cushing's disease, which is slightly different from Cushing's syndrome. Cushing syndrome, as I said, is a clinical manifestation of glucocorticoid excess, whereas Cushing's disease is specifically a pituitary adenoma that secretes ACTH, and that ACTH then stimulates cortisol production in the adrenal glands. That's probably the cause of about 80% of endogenous causes of Cushing syndrome. And then you can also get ectopic ACTH production. So that's ACTH that doesn't come from the pituitary, it comes from somewhere else in the body. So usually a ACTH secreting tumor. And then you can also get cortisol production or overproduction and release from the adrenal glands. And that can be due to an adrenal adenoma or carcinoma or adrenal nodular hyperplasia. So that's how you can separate the causes of Cushing syndrome when thinking about Cushing syndrome. But as I said, the most important and the most common thing to think about when you see a patient who presents with Cushing symptoms is, are they on steroids, and how can we stop or reduce or wean the steroids? So question 2, a 54-year-old lady is reviewed in the general medical ward after being admitted with cellulitis following a cut on her leg. She's recently been diagnosed with hypertension and type 2 diabetes. On examination, she has central obesity, a plethoric round face, bruising on her arms, and proximal muscle weakness. Which of the following is the next best investigation to screen for the most likely cause of these clinical findings?
"30 seconds left, guys."
Excellent. So a bit of a mixed opinion on this one, but most people got the right answer there, which is low-dose dexamethasone suppression test. So the tests, you can think of the tests being split up into screening tests and diagnostic tests. And we always start with the screening tests in in these kind of endocrine disorders, we always start with screening tests, and then we move on to the diagnostic tests, which cost more money and are more time consuming and more difficult to get. So there are a couple of different screening tests that you can use in Cushing syndrome. There's no point in using a random plasma cortisol or saliva cortisol level, because you see diurnal variation in the level of cortisol throughout the day and throughout the night. So doing a random cortisol level is completely useless. A random ACTH is helpful, but it's not. It can be high and it can be low, and neither of those help us in determining whether this could be Cushing syndrome, because in Cushing syndrome, the ACTH may be high or low. It helps us to elucidate the cause of it later on in our investigations. And then we'll go on to low dose and high dose dexamethasone suppression tests in a second. So there are three main screening tests for Cushing syndrome. So if you see a patient with these classical features that we described just previously, you can do one of three tests. One of them is a low dose dexamethasone suppression test. So here we give 1 milligram of dexamethasone at midnight, and then we take a serum cortisol level at 8 a.m. And due to the negative feedback imposed by dexamethasone on the hypothalamus pituitary adrenal axis, or the HPA axis, we would expect to see a suppressed cortisol. So that's cortisol less than 50. And in Cushing syndrome, cortisol fails to be suppressed. So we'll see a higher cortisol. So dexamethasone at this low dose of 1 milligram won't be able to suppress cortisol in Cushing syndrome. There can be quite a lot of false positives when you do this in hospital. So about 1 in 4 of the tests will be false positives. And this is due to a stress response of being in hospital. So people's cortisol levels are naturally slightly higher when they're in hospital. Another screening test for Cushing syndrome is to do a midnight and a 9 a.m. cortisol. So as I was saying before, there's a diurnal variation in cortisol level. So it's usually lowest at around midnight and highest in the morning. And that's how cortisol changes throughout the day. And in Cushing syndrome, you have a complete loss of this diurnal variation. So your cortisol level is constantly high. And this can be measured with serum samples in hospital. So you can take blood from patients at midnight and in the morning, or you can do it as an outpatient at home with salivary samples and test the cortisol level in saliva. This isn't that commonly used because it can be inaccurate. And the third screening test that can be used is 24-hour urinary free cortisol collection. So that's basically you collect cortisol in someone's urine over a 24-hour period. So collect all of the urine in a 24-hour period and then measure the cortisol. And that obviously takes into account this diurnal variation that we get throughout the day. And a normal value is less than 280 nanomoles over 24 hours. And in Cushing syndrome, this is elevated. So these are the three screening tests that can be used in a hospital setting or as an outpatient in terms of the saliva. And the most common one that you'll get asked on your exams and that is used is this low dose dexamethasone suppression test. So question 3. A 55-year-old man is reviewed in the endocrinology clinic. He has a 3-month history of lethargy and weight gain. He's recently been diagnosed with hypertension and commenced on amlodipine, but has no other past medical history. He smokes 20 cigarettes per day and drinks a bottle of wine each evening. On examination, he has a plethoric round face, central obesity, and proximal muscle weakness. 24-hour urinary cortisol and random serum ACTH level are both elevated. Midnight and early morning cortisol levels demonstrate normal diurnal variation in cortisol level. Which of the following is the most likely explanation for this patient's physical findings and investigation results?
30 seconds left, guys.
So this one was slightly harder. The right answer here is chronic alcoholism. So as I said, this patient presents with typical features of Cushing syndrome, of symptoms and signs of Cushing syndrome, with the plethoric round face, central obesity, proximal muscle weakness, as we were talking about before. And 24-hour urinary cortisol is elevated. However, in this case, the midnight and early morning cortisol levels demonstrate normal diurnal variation. And when there's normal diurnal variation, but everything else suggests that there might be Cushing syndrome, this is kind of the typical finding for pseudo Cushing syndrome, which is why it's not steroid therapy induced Cushing syndrome, and why it's not Cushing's disease, because in both of those you would lose the diurnal variation you see in cortisol level. So pseudo Cushing's is basically when a patient presents with the signs, symptoms, and biochemical findings of Cushing syndrome, as we did in this case, but that's not caused by a problem in the HPA axis. So it's not caused by adrenal pituitary hypothalamus problem. And in cases of pseudo Cushing syndrome, we tend to see an elevated 24-hour urinary cortisol, an abnormal low-dose dexamethasone suppression test, high ACTH, but we see normal diurnal variation in cortisol levels, which we don't see in Cushing syndrome. So that's the big difference between Cushing syndrome and this pseudo Cushing syndrome. And pseudo Cushing syndrome is commonly caused by things like chronic alcoholism, obesity, depression, pregnancy. Those are the kind of four big causes. And it's important to remember these when we see patients presenting with symptoms and signs of Cushing syndrome. And it's important to consider looking at the diurnal variation in cortisol levels. And in order to investigate these things and manage pseudo Cushing syndrome, we just need to manage the underlying cause. So, for example, weight loss and obesity, abstinence in chronic alcoholism, talking therapies and depression. And once we've started the treatment for these, we can repeat the Cushing syndrome screening tests a month or two later. So we can repeat the 24-hour urinary cortisol, the low-dose dexamethasone suppression test to see if these have responded to our treatment. So that's pseudo Cushing's syndrome. Important to remember when considering causes of signs and symptoms of Cushing's. So question 4, a 68-year-old man presents to the endocrinology clinic with a history of weight loss and increased skin pigmentation. He was found to have an elevated 24-hour urinary cortisol during a recent admission to the hospital with pneumonia and was referred for further investigation. He still has a cough following his treatment of his pneumonia. He has a past medical history of hypertension and type 2 diabetes, and his investigation results are as follows. So we've got the cortisol after a low-dose dexamethasone administration, and cortisol after high-dose dexamethasone administration. And then we've got an early morning ACTH. So which of the following, based on these investigations, is the most likely diagnosis?
"30 seconds left, guys."
Excellent. So that's small cell lung carcinoma for that one. So in this case, we've got a patient with an elevated 24-hour urinary cortisol. So that's a screening test that's positive for Cushing syndrome. So then we go on to do more. Then we go on to do more of our diagnostic tests for Cushing syndrome. So that includes an ACTH and a high-dose dexamethasone suppression test. And as you can see here, the patient has an abnormal high-dose dexamethasone suppression test. So the cortisol levels are still very high. And they also have a very, very high ACTH. Now, when the high-dose dexamethasone suppression test is abnormal, it implies that there's ectopic ACTH secretion coming from somewhere. And by giving high doses of dexamethasone, we're not able to suppress cortisol because there's ACTH coming from somewhere else that isn't the pituitary. And we can see this from the ACTH level being so high in this case. And when we have such a high ACTH level, we need to think about ectopic ACTH secretion. One of the most common places we can get ectopic ACTH secretion is from a small cell lung carcinoma. And we can see in this patient that he was admitted to hospital for pneumonia and still has a cough following this. So it probably wasn't a pneumonia that he was admitted with, it was probably a cancer, his small cell lung cancer. So in terms of further investigations in Cushing syndrome, once we've confirmed the diagnosis based on a screening, or once we've done the screening tests that increase our suspicion of Cushing syndrome, so if we have a positive low-dose dexamethasone suppression test, an elevated 24-hour urinary cortisol collection, or we've seen a loss of the diurnal variation in cortisol level, we can go on to do these more conclusive tests. And they include the following. So serum ACTH. So this tells us where in the HPA axis the cortisol is coming from. So if the ACTH is high, it implies that there's either pituitary secretion of ACTH or ectopic secretion of ACTH. Usually in pituitary secretion of ACTH, we get a slightly elevated level, whereas in ectopic secretion, we get a very elevated level. And as we saw in the previous case, it was very elevated ACTH. If the ACTH is low, then it implies that there's negative feedback onto the pituitary. So it implies that the problem isn't coming from the pituitary, it's coming from excess cortisol elsewhere. So that could be from the adrenals, or it could be from an iatrogenic steroid administration. Then we can also do a high-dose dexamethasone suppression test. So remember in low dose, we gave 1 milligram of dexamethasone at midnight, and then we measured the cortisol level at 8 to see if it was suppressed. In a high dose, what we do is we give 2 milligrams of dexamethasone 6 hourly for 48 hours, and we measure the plasma and urinary cortisol at 0 hours, so just before we start, and at 48 hours. So just when we finish. And if we see a suppression of cortisol, complete or partial suppression, with the high-dose dexamethasone suppression test, then that's diagnostic of Cushing's disease. And remember, Cushing's disease is an ACTH secreting tumor is ACTH secreting pituitary tumor. So that doesn't respond to low-dose dexamethasone suppression, but it does respond to high-dose dexamethasone. And the cortisol is suppressed in Cushing's disease with high-dose dexamethasone. However, if we see no suppression in the high-dose dexamethasone suppression test, then it means that the ACTH is coming from somewhere else. So ectopic ACTH, which is what we saw in this case. We can also give a slightly rarer test is to give corticotropin releasing hormone. And we give that IV, and then we can measure cortisol at 2 hours. Corticotropin releasing hormone stimulates ACTH release from the pituitary, which then obviously goes on to stimulate cortisol production. So if we see a cortisol rise when we give CRH, then that implies that the cause is Cushing's disease, and we're just stimulating the HPA axis, and we're stimulating increased ACTH production from the pituitary. If there's no rise when we give CRH, then it means that there's probably ectopic ACTH. And by giving CRH and causing an increase in the ACTH secretion from the pituitary, it's having quite an insignificant effect because there's already so much ACTH in the body from the ectopic secretion. So that's why we get these test results from a CRH test. So those are 3 tests that we can do to confirm the findings and confirm the cause of Cushing's syndrome. So question 5, a 45-year-old man presents to the GP with fatigue, irritability, and difficulty concentrating. He's noticed a 5-kilogram weight gain in the last 2 months. He has no past medical history. On examination, he has a plethoric round face, excess fat around his neck, and central obesity. An early morning cortisol is elevated, so he's referred for further investigation. The results of which are as follows. So we've got the cortisol after low-dose dexamethasone administration at 683, cortisol after high-dose dexamethasone administration at 236, and an early morning serum ACTH at 18.4. Which of the following is the next best investigation?
"30 seconds left, guys."
Great, so the answer to that one is MRI pituitary gland. So this case, again, we've got the typical features of Cushing syndrome, the signs and the symptoms, and the screening test was positive, so he's been referred for further investigation. The low-dose dexamethasone suppression test is abnormal. So that's our screening test being positive. And the high-dose dexamethasone suppression test is normal. Remember we said when that happens, when the low-dose dexamethasone is abnormal and the high-dose dexamethasone suppression test is normal, then that's diagnostic of Cushing's disease. And that's an ACTH secreting pituitary tumor. And as we said before, the ACTH here is slightly elevated. And that's what we see in Cushing's disease, the ACTH secreting pituitary tumor. And that's different to the ectopic ACTH secretion where ACTH is much, much higher. So this is a case of Cushing's disease. And so we want to image the pituitary gland to see if we can see the tumor, which is why MRI of the pituitary gland is the right answer here. CRH test could be done, but it won't really offer any additional information because we've already diagnosed Cushing's disease from our low-dose and high-dose dexamethasone suppression test. So this is a kind of framework of an approach to Cushing syndrome and the different investigations that we can do and the different management options that we can consider once we have a diagnosis, once we've screened for Cushing's. So if you have a positive Cushing's screening test, so a positive low-dose dexamethasone suppression test, positive 24-hour urinary cortisol collection, or a loss of diurnal variation of cortisol, the next thing we can do is take a serum ACTH level. Once we've taken the serum ACTH, if this is high, then that implies there's either pituitary ACTH secretion or ectopic ACTH secretion. So the next step is a high-dose dexamethasone suppression test or a CRH test. If these show no suppression and no change in the cortisol level, then an ectopic cause, an ectopic ACTH secretion is most likely. And in this case, the next investigation to do is CT, chest abdo-pelvis, or MRI, to see if you can find the cause. However, if the high-dose dexamethasone suppression test and CRH test do change the cortisol, then a pituitary cause is likely. And in this case, we do an MRI of the pituitary. If we see a mass on the MRI of the pituitary, then we can refer to the endocrine surgeons or the neurosurgeons for management, so transsphenoidal surgery. That's usually the neurosurgeons, to remove the tumour. If there's no mass on MRI of the pituitary, but we have diagnosed what we think is Cushing's disease, but we can't see the mass, then we can do bilateral inferior petrosal sinus blood sampling for ACTH. That's where you sample blood in the venous sinuses of the brain to see if there is increased ACTH secretion there. And that's a very accurate way of telling if there is Cushing's disease. If we go back up to the other side of this chart, serum ACTH is low, then it means that an adrenal cause is most likely, or an ectopic, or an exogenous cause. So we are giving steroid. But if we're not giving steroids to this patient and the serum ACTH is low, then cortisol is probably being released from the adrenal glands. So the next step is to do an adrenal gland CT. If we see a unilateral mass, so a mass only on one side, we can do an adrenalectomy and maybe give radiotherapy, maybe give mitotaine, which is basically a drug that's used in adrenal cancers. If we don't see a mass on CT of the adrenal glands, then like with the pituitary gland, we can do vein sampling, so adrenal vein sampling. And that way we can see if one adrenal gland or both adrenal glands is secreting excess cortisol. And then we can guide our management from there. So question 6, a 36-year-old woman presents to the GP with weight gain and low mood. She has a history of rheumatoid arthritis diagnosed 3 years ago, and this has been well controlled with methotrexate and prednisolone. On examination, she has central obesity, proximal muscle weakness, and purple abdominal striae. Thyroid function is normal and other routine blood tests are unremarkable. Pregnancy test is negative. Which of the following is the next step in the management of this patient?
"30 seconds left, guys."
Good, so wean prednisolone therapy is the answer here. So this lady again has symptoms and signs of Cushing's syndrome. And the most likely cause here is the prednisolone therapy, because she's been on steroids for 3 years, which is a long time to be on steroids. So the rheumatoid is very well controlled in this lady. So it would be the most important step in the management of this patient is to start to try and wean that prednisolone therapy on discussion with the rheumatologists, the people who started the therapy in the first place. It wouldn't be unreasonable to organise low and high dose dexamethasone suppression tests, but in someone with such a clear history of excess steroid intake, the first step that you would do in the management of this patient is wean the prednisolone therapy first and see if that reverses some of those signs and symptoms. So in terms of the management of different causes of Cushing's syndrome, as we've just mentioned with this case, in iatrogenic Cushing's syndrome, we want to try to wean the steroids as much as possible. And we need to be discussing with the team who started the steroids. So if it was the gastroenterologist who started it for Crohn's or the rheumatologist who started it for rheumatoid arthritis, we need to discuss with that team and try to wean the steroid therapy as much as possible by using steroid-sparing agents, such as methotrexate, azathioprine, things like that. If someone's had chronic steroid exposure for many years, they can often suppress their own HPA axis, so suppress their own cortisol production, which means that they may require long-term low-dose steroid therapy to avoid adrenal insufficiency and Addisonian syndrome. Cushing's disease, as we've already mentioned, can be managed with transsphenoidal surgery, and that's surgery that will remove the pituitary adenoma. And if there's a recurrence of the Cushing's disease after the pituitary adenoma has been removed, then patients can have a bilateral adrenalectomy as well. In terms of an adrenal adenoma or carcinoma, you can have a laparoscopic adrenalectomy. And as I said before, if you have a carcinoma, you may need radiotherapy or mitotane. And if you have an ectopic ACTH secretion, you can have surgery on the primary tumor. So if it's a small cell lung cancer, then you would have that treated, or whatever the primary tumor is, you want the primary tumor to be treated. And you can also give these other drugs called meteroplone, ketoconazole or fluconazole, and they all inhibit corticosteroid synthesis. So they can be given preoperatively or for post-op recurrence of Cushing's syndrome. So question 7, a 45-year-old woman with poorly controlled hypertension is reviewed by the GP. She's been diagnosed with hypertension for years and is currently managed with optimal doses of ramipril, amlodipine and benzoyl-flumethazide, yet her blood pressure is still not controlled. She has no past medical history. She reports regular muscle cramps and occasional weakness, but no other symptoms. And blood results are as follows on the left. Which of the following is the most likely diagnosis?
"30 seconds left, guys."
Great, so the answer to that one is Conn syndrome. So the first point to pick out from this question is that this is a young lady with poorly controlled hypertension who's required 3 different antihypertensives and her blood pressure is still not controlled. When we see patients like that, it's really important to consider secondary causes of hypertension. she has no other past medical history, so she's never been diagnosed with anything else. So really important in young patients with poorly controlled hypertension to consider other causes of hypertension. The blood results show that she's hypernatremic and hypokalemic, and that she's slightly alkalotic on her blood gas. So in a patient with hypokalemia and hypertension, that we should be thinking Conn syndrome, and that automatically points to Conn syndrome, as opposed to any of the others. So Conn syndrome is also known as primary hyperaldosteronism. So the over secretion or the excess secretion of production and secretion of aldosterone. So that's our mineralocorticoid. And that aldosterone usually causes sodium reabsorption in the kidneys and potassium secretion in the kidneys. And with sodium reabsorption, water follows, so you get water retention as well. So the causes of Conn syndrome can be split up into adrenal adenoma, which is a kind of aldosterone secreting mass in one of the adrenal glands, and that makes up about 2/3 of the cases, and the other third of cases are made up of bilateral adrenal hyperplasia, and that can often be congenital. There's also familial hyperaldosteronism and adrenal cancer, which make up some of the causes of Conn syndrome as well. As I was talking about before, when we come across young patients with poorly controlled hypertension on multiple different agents, it's important to consider the secondary causes of secondary hypertension. So these can be split up into renal causes, endocrine causes, and other causes. In terms of the renal causes, about 3/4 of them are made up of intrinsic renal disease, so glomerulonephritidis, chronic pyelonephritis, sclerosis, polycystic kidneys. And the other quarter are made up of renovascular disease. So that's things like renal artery stenosis, which can be caused by atherosclerosis or by fibromuscular dysplasia. Endocrine causes of secondary hypertension include Cushing syndrome, Conn syndrome, pheochromocytoma, and acromegaly. However, if you see hypertension in Cushing syndrome, it's usually bad enough to have caused lots of other signs and symptoms of Cushing syndrome. And other causes of secondary hypertension include pregnancy, aortic coarctation, things like that. Question 8. A 42-year-old man is reviewed on acute medical ward after presenting with a short history of headache and blurred vision. He reports no fever, neck stiffness, dizziness, or weakness. He has a history of hypertension for which he is currently managed with amlodipine, losartan, bisoprolol, and oxazicin. He reports good compliance with his medication. Blood pressure is 184/103. Physical examination is otherwise unremarkable. Urine dip is negative, and ECG shows normal sinus rhythm with some evidence of left ventricular hypertrophy. Urine and plasma metadrenalins have been requested, and the blood results are as follows on the left. Which of the following is the next best investigation in this man?
"30 seconds left, guys."
Excellent. So the answer is aldosterone to renin ratio. So in this case, again, we have a young man with poorly controlled hypertension on multiple different agents. We can see that he's currently got quite a high blood pressure, but he has no evidence of end organ damage. So it's important, again, here to investigate causes of secondary hypertension. And his blood tests demonstrate, again, this slightly elevated sodium at the upper end of normal and hypokalemia. So this, again, points towards Conn syndrome as the cause of his secondary hypertension. And the best screening test for Conn syndrome is an aldosterone to renin ratio, which is much more useful than a serum aldosterone level, which doesn't really give us an accurate representation of the renin-angiotensin-aldosterone axis. Thyroid function, hypothyroidism can cause high blood pressure, but if hypothyroidism is causing high blood pressure, we would tend to see lots of other signs and symptoms of hypothyroidism. Cushing syndrome, as I said, can cause hypertension, but again, we would expect to see other signs and symptoms of Cushing syndrome. And MRA of the renal arteries is a reasonable investigation to request in a patient with secondary hypertension, but would probably do more simple tests first, such as urine and plasma metadrenalines to look for pheochromocytoma, and aldosterone to renin ratio, which is another simple blood test that we can take before we start doing investigations like MRAs of the renal arteries to look for renal artery stenosis. So I've put up the renin-angiotensin-aldosterone system here, which I'm sure everyone is familiar with. And this is what we are, this is the system that we're kind of looking at when we do an aldosterone to renin ratio. And in Conn's syndrome, because we have a hyper secretion of aldosterone, that causes a negative feedback by way of onto the renin. So we'll have reduced renin. And that's by way of aldosterone's action. So as I said, aldosterone causes sodium reabsorption and water retention, which means that renal perfusion will be increased and improved, which means renin secretion will reduce. So we would expect to see high levels of aldosterone and low levels of renin, which means a very, very high aldosterone to renin ratio. When we take an aldosterone to renin ratio to look as a screening test for Conn syndrome, posture tends to affect these results. So ideally we do it with the patient being upright or sitting for 2 hours instead of lying down. Antihypertensives should also be withheld. So we tend to try and withhold as many of the antihypertensives as possible for 2 weeks. And we need to hold spironolactone for 6 weeks. And we can still give things like alpha blockers because they don't have an effect on the renin-angiotensin-aldosterone system. So that's things like doxazosin. As well as the aldosterone to renin ratio, we can also do suppression tests. Like we did with dexamethasone suppression in Cushing syndrome, we can do fludrocortisone or saline suppression tests in Conn syndrome. And these tests are basically, we give fludrocortisone, which is a mineralocorticoid, and see if that reduces the secretion of aldosterone. Or we can give saline and see if that reduces the secretion of aldosterone. By giving saline, we're increasing the renal perfusion, reducing renin secretion, and therefore that should reduce aldosterone secretion. But in Conn's syndrome, it doesn't. So Conn's screening test is aldosterone to renin ratio, and then more diagnostic tests we can do or are these suppression tests. Question 9. A 39-year-old woman is reviewed in the endocrinology clinic. Her GP has referred her due to abnormal blood results. She has a history of poorly controlled hypertension and is currently managed with captopril, amlodipine, doxazosin, and bisoprolol, but her blood pressure is still uncontrolled. She has chronic hypokalemia requiring ongoing potassium replacement, and aldosterone to renin ratio was significantly elevated. A CT of the adrenal glands demonstrates no obvious nodules, and adrenal vein sampling demonstrates increased aldosterone production from both adrenal glands. Which of the following is the next best step in the management of this patient?
Thirty seconds left, guys.
Yeah, so the first step in the management is in these patients. So this patient has Conn syndrome, as we can tell from the hypokalemia and the poorly controlled hypertension, and evidence of bilateral adrenal hyperplasia. So the first step in the management of these patients is to give spironolactone, which is an aldosterone inhibitor. Benzoflumethiazide is a reasonable addition in patients with hypertension after giving an ACE inhibitor and a calcium channel blocker. But in this patient, as we've seen, the diagnosis is probably Conn syndrome, and spironolactone is the first step in management. Bilateral adrenalectomy wouldn't necessarily be the best next step in the management of this patient, because spironolactone is a much simpler, easier, safer management step to use, and would definitely be the thing we tried first to see if we can block the aldosterone production secretion effect as much as possible before we go on to anything more drastic like adrenalectomies. So in terms of an approach to Conn syndrome, once we've confirmed Conn syndrome on our screening investigations, so once we've done our aldosterone-renin ratio and we've maybe done a saline suppression test or a fludrocortisone suppression test, the next thing we can do in terms of investigations is an adrenal CT or MRI. And if we see a unilateral mass on our adrenal CT, then we can be pretty sure that the aldosterone is coming from that mass. And so the next step, again, as with Cushing syndrome, is an adrenalectomy. If it's a cancer, we can give radiotherapy and mitoting. If we don't see any masses on the adrenal CT or MRI, or if we see bilateral nodules, so both sides, sometimes we can trial glucocorticoids. And there's this thing called glucocorticoid remediable aldosteronism, which is where if you give steroids, your hyperaldosteronism gets better. It's not very well defined in the literature, and its causes aren't very well elucidated, or its mechanism. But that is something that can be trialed if we don't see any obvious masses on the adrenal CT. If there's no response to this glucocorticoid administration, then we go down to this section where we can again do adrenal vein sampling, and we can see which of the adrenal glands the aldosterone is coming from. If we see increased aldosterone production from only one of the adrenal glands, then we go back up to this step and we do an adrenalectomy on that side. If we do adrenal vein sampling and we see increased aldosterone production from both of the adrenal glands, then we can give medication to block the effects of aldosterone. So that's things like spironolactone or eplerenone, or we can give things like other diuretics like amiloride, which will inhibit the reabsorption of sodium in the kidneys. So that's kind of an approach to the elucidating the causes of Conn syndrome, and also to how we manage different things how we manage these different causes of Conn syndrome. Conn syndrome is very rare as a cause, very rare in general, and very rare as a cause of secondary, and quite rare as a cause of secondary hypertension. But obviously important to consider and quite easy to rule out with those simple screening tests, if we do find it. So that's the end of the SBAs. Here are a few apps to download the Quesmed app if you haven't already got it. There's a few questions that people have put on. Sanya, did you want me to go straight into the questions?
Yeah, sure. Just before that, just 1 second. If you guys could fill in the feedback forms, I've put in the links in the chat. That would be fantastic. And yeah, sure, we can go on with the questions. Thank you, Jamie.
Excellent. So the first one is, when do we use high-dose dexamethasone suppression test? And I think I've already covered that in the lecture so far, but basically are positive. We can then go on to do serum ACTH and a high-dose dexamethasone suppression test. And the point of that is to try to elucidate the cause of Cushing's syndrome, and to see if it could be Cushing's disease or an ectopic ACTH secretion. And then, why is ACTH not suppressed when using low-dose dexamethasone suppression in pseudo-Cushing syndrome? So pseudo-Cushing syndrome is basically where you have all the signs, symptoms, and biochemical findings of Cushing's. So that includes the low-dose dexamethasone suppression test being positive. It's not fully understood why the cortisol isn't suppressed in low-dose dexamethasone suppression tests in pseudo-Cushing syndrome, and it's basically just an important investigation, important causes of signs and symptoms of Cushing syndrome to bear in mind. So understood, not very well understood why cortisol is not suppressed in pseudo-Cushing syndrome, but it is kind of fairly well described that there is that normal diurnal variation in pseudo-Cushing, sorry. What are the symptoms of Conn syndrome? Is it just symptoms of hypertension? Yeah, so it's either symptoms of hypertension or symptoms of hypokalemia, which can be odd sensations, muscle weakness, fatigue, things like that. Often it will just present as someone who's gone to the GP or gone to hospital and they've been found to be hypertensive, and then it will go on from there. They'll be started on antihypertensive medication. They won't be controlled on antihypertensives. More will be added in, and then eventually they will have that someone will do an aldosterone to renin ratio. So yeah, Conn's doesn't really necessarily have any symptoms apart from this manifestations of its hypertension and hypokalemia. Why does posture have an effect on aldosterone renin ratio? It's all to do with the perfusion of the kidneys, which can be altered by posture, basically, and shifts of fluid around the body. So that's basically to remove any sort of potential confounding factor when we're doing that test, which is why posture has an effect on that aldosterone renin ratio. What is adrenal Cintigraphy? So yeah, I don't really go into this that much. So we can do adrenal vein sampling, or we can do adrenal Cintigraphy, and that's basically just like a PET scan or SPECT scan of the adrenal glands. So it uses traces that the adrenal glands pick up, and we can see if one of the adrenal glands is more active than the other, basically. it's a bit like any other PET scan. And so that is another option versus the adrenal vein sampling to see if there's increased cortisol or aldosterone production from one kidney. It kind of tells us one adrenal gland. It kind of tells us if one adrenal gland is more active than the other. And is the low-dose dexamethasone suppression test a screening test? Yes, it is a screening test. Because it tells us, because if it's negative, then it tells us that this is not Cushing syndrome. And if it's positive, so if it's an abnormal test, then it tells us that this is Cushing syndrome, but it doesn't tell us which cause of Cushing syndrome it is, which is why we'd define it as a screening test instead of as a kind of diagnostic test. And that's it for the question. Are there any other questions that anyone has after that?
Yeah, if anyone has any questions, they can pop it into the Q&A or even the chat really quickly. And I have the feedback forms on the chat, so if you guys could answer them, that would be absolutely fantastic. But I think you answered them so fast, Jamie. I think that everyone's just thrilled with this amazing session. So I would like to say honestly, I'd like to say thank you so much for everyone who's been attending. Please fill in the feedback form. I'm going to stop the recording now.